It's such a pleasure being with you this evening. Now, what are we doing here? Well, let me tell you very quickly. This is a dialogue on cancer, and it's a partnership between Brimstone Investments and Groote Schuur Hospital. And I'm not saying this because, I'm here with doctors and professors and people who've been treated at the institution. I've got lots of respect for this public institution that does amazing work on a daily basis. Today, as I said, we are going to be talking cancer. My name's Kieno, Kammies. I did retire from media, but when it comes to these sort of things, something that's close to my heart, I will always say yes. Personally, I had a father who passed away of throat and lung cancer at the age of 75. It was a very, very difficult journey. It's even difficult to think about it and what my dad went through. And you start realizing that this is not just your journey. It's a lot of other people's journeys out there. And that is what we're doing tonight. We're telling stories of the cancer journey. And hopefully you take something home with this after this particular discussion. So let me introduce you to the guests this evening. We're going to be chatting to the two amazing human beings, one on my left, one on my right. We've got Raldia Jackson. Great to have you here.
Thank you.
Can't wait to hear your story. Desiree, Fiellies, great having you as well.
Thank you.
And then we're going to be chatting to the doctors. Now, our doctor is Dr. Julie Wettter, an oncologist at Groote Schuur. Good being in your presence. And the head of radiology. I got that right, eh? The head of radiology, Professor Sulaiman Moosa. Good to have you here as well.
Thank you.
Brilliant. I love storytelling. When I used to be in the media, I preferred people telling stories. Now, stories can be sad, stories can be uplifting. And I would like the two of you, Raldia, we'll start with you. I'd like you to tell me the story about you. Who are you? Tell us a bit about yourself. Before we talk about cancer, before we talk about anything else, tell me about you and your family.
Okay, I'm Raldia Jackson. I'm 49 years old. I'm a registered nurse at Groote Schuur Hospital.
Oh, okay.
Operational manager, but we keep it as the registered nurse.
Right.
I've been by Groote Schuur since 2000. I started my nurse degree in 1996. And when I was doing my R4 to 5, and then I started at Groote Schuur in January 2000, and I've still since been there in the theatre, operating theatre. So we rotate through the theatres and do a little bit of everything. So if I can tell you about Groote Schuur theatres, it's a very big complex. They've got different surgeries, like orthopedics, gynae, cardiacs, ENT, urology, plastics, max-fax, and we've been through all that.
A lot happening. There's a lot happening.
It's a lot happening.
Absolutely.
Yes, and for the last 7 years, I've been the operational manager of the day surgery theatre.
Okay.
That's in the OPD building.
A rumor tells me you used to do scrubs as well before that, yeah?
Yeah, scrubs. I was a scrub sister for all the years. That just means you are the person that stands next to the doctor and hand him his instruments.
So the doctor better be nice to you.
You better be nice to me, otherwise I give him the wrong instrument. And if you don't know, then I tick you on the fingers.
Oh, is it? Okay, I wouldn't mess with you. But okay, we understand what you do, your work. You do amazing work. You're an operations manager. Tell me about your family.
My family, I've got
your immediate family, so
yes,
your kids and yeah.
I've got two daughters. They are 16 and 18. One is in grade 10 now. The other one is studying cosmetology. It's beauty and makeup. That she's doing her first year. And then I've got a wonderful husband, actually a second husband.
Okay.
And we have one kid. He's got one kid. So my little stepson of 13 years old.
Oh, wow. Sounds like an absolutely amazing family. So what we're doing here is we're getting to understand the people behind the discussion. Too often we talk about cancer. We talk about, this thing that invades the body. Could cost you your life. You need to get good treatment. But who are the human beings who actually have to deal with the cancer? So you've heard of Raldia, of course, Raldia Jackson. But Desiree, Fiellies, what about yourself? Tell us a bit about you. Give us some insight into you and your family.
Okay, my name is Desiree Fiellies. I'm 50 years old. I'm going to be 51 on Sunday. Yeah. I'm a housewife. I resigned last year. I was 28 years in the Wettter and in engineering.
Right.
I was in electronics field. So because of my arm, I resigned, stayed at home. And I've got 2 kids, a son 22 and a daughter of 13, and he's studying at CPUT, doing graphics design. It's last year. And my daughter is in grade 7.
Wonderful.
And then I've got a husband, and he's working at Rheinmetall.
Okay, so the next thing I'd like to move to is, and maybe Raldia, for you it's different, right? Because you were been in surgery, keeping the doctors honest and all the rest of it. What was your view of cancer before you got it?
Well, before I got cancer, you just think, even as a nurse, you do all the surgery, you do mastectomies and things, and that even it's a patient that's there, but you don't think further than that. You know, okay, the patient has got cancer, say he's got breast cancer, and you know you're taking the breast off and the lymph nodes and that. And then they go to the ward. And sometimes we do follow up and say, and go back to the patient and say, okay, how are you doing and things. But you don't think further than that. Chemo and radiation is just a word. You don't know what it means. And then there isn't that. I will say we are always sympathetic towards our patient, no? And we feel. But if you go through the journey yourself, then only you understand what that patient goes through, and then you understand better. But before that, like, okay, there's another patient for a mastectomy, and then you go
So it just
and you
becomes
scrub.
work,
It's
right?
But you don't really understand what that patient and what the family is going through.
And it must be a difficult thing. I mean, you're dealing with people and suffering, etc. But you also need to do your job. You need to make sure that you play your part, and that's all you focus on. What about yourself, Desiree? Have you had any exposure through family, or what was your relationship mentally with cancer before you got it?
I always thought that I always had this problem of my breast paining, and went every year for a mammogram and all that. And I always thought that, am I going to get one day breast cancer because of my breast that's always like sore, and they always see some things, but then they say that's fine. And then, it was a shock when it came to me. But I said to myself, I had to deal with it myself, and life goes on after this. And I actually prepared myself a long time. If I get cancer one day, how I'm going to be, you see? So I said to myself, no, I must look forward now.
Tell me about the day you found out you had cancer.
Okay.
What went through your mind? How did you feel? You know, we prepare for things. It's a bit like we know our parents are getting old and we prepare for death. But when it happens, it's not as we've imagined it. It's so just from your perspective, when you found out that day that you've got cancer, talk to me about how
Okay, the day when they said there's a lump in my breast, when the ultrasound showed there's a lump in my right breast. And I didn't even know. I didn't even feel the lump in my breast. Nothing. There was nothing that showed that I have cancer.
Yeah.
You know, sometimes the breast must. And then the doctor said there's a lump, and it's not big, it's a small lump. But they first going to do a biopsy, and so after biopsy, they said it's cancer, and then they booked me most now for the operation.
What went through your mind?
I was laying there, and then the guy went to call the lady, and when before she came in, I was laying there, and I said, God, I'm putting everything in your hand. I'm not depending on no one around me. I'm depending on you. It's you that's going to carry me through from today up to what is laying ahead of me. And then I was just calm.
Calm.
Yes. When I got home, I said to my husband, I'm just going to wait for the 2 kids to come. And then I said to them, they must sit. And I said, Conway, Nadine, you know, Mommy went for the checkup on my breast, and you know there's a lump, and it's cancerous. I don't know how did they take it, but I said to them, we're gonna, you must treat me normal. We're gonna carry on as normal. I'm not sick. Your mommy's gonna be fine.
Yes.
We work from here up to I get my operation. And then they were okay.
Supportive as a family would
Yes,
be, obviously.
yeah.
Because, I mean, I would imagine there are times when you put your head down at night. We can't help but think
Yes.
about the fact that I've got a cancer. How's it going to turn out? But, of course, as you say, you've put your faith in God, and your family was there, and that really helped you through.
Yes, my family, all my cousins, everyone was there, my friends, phoning, praying, and
That helps when you've got
a
that
lot,
tough.
yes. They were very,
So, the community is so important when dealing with this as well.
yes.
Desiree, thank you for that story. And what about yourself, Raldia? So here you are, you in and out of theatre. You explain to us how you feel, it's your job and you do it. Tell us about the day you got the news.
Well, let me start back. In November 2018, so I felt I felt a lump here under my arm.
Yeah.
But I thought, okay, I'm on leave. I will go in January when I go back, because my theatre is on the floor that the breast clinic is in.
Okay.
So I can just go there and say, get my folder, and can somebody see me? So the first week in January in 2019, when I went back to work, like the Wednesday, I said, okay, Sister Lynch, can I come to the breast clinic on Friday? I felt a lump, I think. But me thinking, on a Monday, we do the breast lumps in my theatre, and that patients come and they remove the lumps, and that's a non-cancerous patients. So I thought, okay, it's a lump, it will be like that. So I went, I saw doctor, and doctor said, no, I don't think it's anything to worry about, but I'm sending you to Dr. Mawerebe, and he can do a biopsy. Oh, okay, we did the biopsy, and so they take the cytology and the histology.
Yes.
So the cytology came down a few hours later, and the histology was for 3 weeks later. So the afternoon, they said, can you wait a few hours and things till the results came out? I said, yes, it's fine. And we went about and things. When I came back, Sister Fish was looking for me. She said, okay, what is the results? What did it say? She said, no, you must come with me. I want to talk to you. And now she said, can you go do your way? Can you go away quickly? Why?
But isn't that the worst thing, right? You go to a doctor, you go for a test, and they say, no, I need to talk to you.
Yeah.
Then all sorts of things go through your mind.
Now she said, go away and go take your height. I don't know why, you must just give me my results. And I go in the room, and now the nurse is there, and now she takes out the other file. Now I'm looking at her and I say, why are you taking out that file? That's not my file. Why are you taking out that file? Because it says radiotherapy on there. And now sister say, okay, it's not my duty to tell you, but your the test was positive for breast cancer. I started crying. My heart went. It was so heavy thing on my heart, on me, and I just started crying because it's just now a death sentence to me. Because just in December, one of my colleagues that worked with me died of breast cancer.
Okay.
And the first thing is, I'm going to die. You are not telling me that. And I cried then. And they just consoled me and things. And after a few minutes, I said, what is my next step? What am I going to do now? Or what must I do now? So she said, okay. She now told me that, but I need to go see the oncologist next door, and he's going to tell me.
Okay.
And so when I went there, he also said, it came now, you're positive for breast cancer, but we also must wait for the other results to come out. And then you will come see us again by the LE33 clinic. And you have to tell your family. And so my daughter and her father was there. And when I went out, I just said, so my office door is just there. So I opened up and I said, come in here. And I just said, Laika, Junaid, they say I've got breast cancer. And my daughter cried. My daughter, Mommy, are you going to die now? That was the first words, Mommy, are you going to die now?
Yeah.
And I didn't know what to tell my daughter. I just hugged her, and I didn't know what to do. Because now I found myself on the other side.
Absolutely.
From now, and I must now hear this news that all the other people hear. And I didn't expect it. There was a lump, yes, but I didn't expect it's going to be positive for cancer. And then we had to go home, and my mommy was there, and I sent a message to my brothers and my sisters, can you come to the house tonight?
Yeah.
I've got something to tell you. And even then, that evening, when they were all there, I said, I've got breast cancer. And they were all looking at me, what? How can you just say it like that? So I'm like, how must I then say it? I don't know how to say it. And everybody was, my daughter ran out again. The other one was crying. My sister looked at me. My mother looked at me. And I'm standing there frozen. I don't know what to do. And so then my sister just came and she hugged me and said, it's going to be okay. We're going to deal with this and we're going to get through this.
And they were your
they were my
rock and your pillars.
And they were my support the whole journey through.
Yeah. When you see people come in for treatment now, post your experience and your current experience, obviously, do you see them differently?
I see them differently. I totally see them differently.
Yeah.
Because now I know what journey lies ahead of them. And then I will go talk to them and I will ask, what did doctor tell you? Do you have some questions? I don't tell them, no, I also had breast cancer and things. I will just say, can I give you a little bit of advice? No, and then say, this is what you do, and this is how you treat your arms, like for the lymphedema, do the exercise, massage your arm, don't do heavy lifting and things like that. And then I tell them, your support, rely on your family and for the support. And then, there's always numbers also that you can phone for cancer and other, I can't get to the name now, reach for recovery. No, there's always that people that can help if you're unsure or anything. And also the people by the LE33s and 32s clinics, they are all very nice and they can help.
Yeah.
So, yeah.
So we're going to talk to Dr. Wettter and Professor Moosa a bit later from a medical perspective, right, as well. But I think what you're saying here, and I think both of you would probably bear me out in this, it makes a world of difference when people actually take the time to find it and to give you advice for you, the person, not just what you have and the treatment that you need to undergo. To know that there's someone who actually cares does make a big difference. So I want to actually, and I think it's going to be a wonderful transition to our discussions with the professor and the doctor. There's this perception that when you go to the public healthcare system, it doesn't work. You're probably not going to make it out. It's better to go to a private hospital. And those people, and it's mainly people on medical aid who've got those ideas. But anyway, I had a father who went to a public hospital, and I was impressed. Talk to me about your experience at the hospital, how you were treated there, and your journey. So Desiree, let's start with you.
Okay. Yeah, they look nicely after me. I can't complain about Groote Schuur, really. From the day when I went there, and the doctor sent me to Groote Schuur to OPD, and up to my operation, all the procedures that I had to go through, they were nice looking after me. And even when I went into theater, the doctors and the nurses, they were very supportive and talked to me. And
caring. Yes,
caring, yes. And even when I went for my radiation, the ladies there, they were, I don't have words because I was very nervous. I was scared because I didn't know what was laying ahead for the radiation. And because of my arm, I couldn't move my arm, but they helped me a lot, yeah. They were very nice.
Yeah, it's good, and we need to tell more of these stories. We need to break down this perception that just because it's the state, it's not going to work. We're not talking about electricity here. We're talking about a healthcare system with people who, and all respect to the electricity, Eskom and friends, but here are doctors who, yes, a lot of them work in the private healthcare system as well, but you're getting the same care when you go to a Groote Schuur. You're getting the same care that you would, I would imagine, if you go to a private institution. So tell me about yours, Raldia, your experience in the hospital. Now, you're part of the team, right? Now you get treated by the team. So what was that experience like?
Well, being the patient was difficult for me, but also that the nurses are so caring especially in the cancer wards and things, I think they are a little more caring and more empathetic because they know a lot of the patients, what the journeys they go through. And you are just a little bit more patient with them and things. And mine as a nurse, I wasn't a nurse there. I was a patient. I was really a patient. I didn't know anything. So I will ask, sister, how do you do this now? Sister, what is next? Sister, what must I do? Because like everything I knew went out of the door. I'm a patient now.
Yeah.
And I can really say the staff is wonderful. The staff is wonderful.
Could you order extra food that other people couldn't get? No, that was a perk. You know, if you. Yeah, no, I think we laugh about it, and I think there are some things that one can laugh about, but when you're in that journey, it's your life, it's your family. I'm sure both of you thought more about your family than you did about yourselves.
Yeah.
Yes.
I must get healthy and I must get through this because my two daughters, what is going to happen with them? I know my sister is there, my mom is there, they will look after them, but they're not the mother. That's not us, and they need their mother.
Absolutely.
Even when I was on chemo and they said isolate for the first 3 days and you keep the children away, they must use their own bathrooms. And when my daughter got sick, I couldn't tell her, that's why, let me just say the names. I couldn't tell her, you can't come to my room. And you have to. I got up and I let her lay next to me and think I looked after. The next day I was sick, but I didn't care because she's my daughter. She needed my help that time. So that you always first think about your children.
You find your own strength in your own pain to be able to get up and yourself. Did you find that as well? Did you worry more about your children, your family?
Yes, I was thinking a lot, especially my daughter. The son is so big. But yeah, the father was there and my sister and my mommy was always there for them, phoned them, and my neighbors was there for them.
That's really good. That's really good. Now, we're going to get to the doctor and the professor as well. I know they're probably looking at me going, hey. No, I'm just kidding. Where are you in your journey at the moment? I think to wrap up this conversation, where are you with your journey right now?
Okay. Yeah. What I can say about this journey,
if you're not comfortable talking about it, it's fine as well.
No, I'm fine. I just put my trust in God. And He has carried me through, it's now 2 years, and He was there from day one up to now with me and with my family. And all I can say about this thing, it's not a death sentence. If you hear about it, people, everyone is not the same. Everyone don't go through the same. Like I just went for radiation. Other people, they go through chemo and radiation. So I can't say that I'm the lucky one because people don't know what I'm going through. See, so yes, this journey, it's gonna be there, but it's how you're gonna walk through this journey. And with God, you can do everything. Yes.
And it really is brave to sit and share the story in front of a lot of people. But it's going to help other people in their journey as well. So Desiree, I want to thank you. Right, I'll come back to you and we'll have more conversations, but I just want to thank you for actually agreeing to be here. And yourself, Raldia?
Well, I had 6 months of chemo. I'm one of the unlucky ones. And I had all the side effects. So from nausea, and doctor said 3 days, 5 days max. I had nausea for 2 weeks. Every time just before, because my treatment was every 3 weeks. So just before I went to for my next treatment, then I feel a little better for that 2 days before. But nausea right through. And then by my second treatment, my hair fell out. Oh, it was so traumatic. Even though you expect it to happen, it's still emotional and traumatic. And then by the third treatment, they said, okay, your bones is gonna pain. So all the inside of your bones, I never knew your bones here and there and everywhere.
All over.
Everywhere, all over, it pains. Yeah, and then there was a time that I couldn't walk properly because my skin was peeling. at the bottom of my feet. My hands got numb, and the pins and needles. I had everything in excess. So, yeah, it was it was very traumatic for me and emotional. But my family support was there, and you learn to pray and sit on, like we sit on a musla and we pray. So that I did in the evenings and just through the nights. So your faith and your family support, very important.
Absolutely.
And then I went through 35 days of radiation.
35.
Yes, and that is like every day you must go there. And then I also had a year of a septin treatment. That's the injections that you also go for every 3 weeks. And now currently I'm on the tamoxifen still. I still have 2 years, 2.5 years to go. I go every 6 months for my mammograms and my ultrasounds. So I can say I'm glad it's over. Yeah, it wasn't easy. And those people that goes through it, I know there's some people that go through it and are, I don't know if I have to say lucky, but they have no side effects. No, but then there's the people like me that had everything. And yeah.
Some of the people who don't have all the side effects could probably go through more emotional turmoil, for example.
Else,
so it's not always the same.
Yeah, that's why I said I can't
right?
say the lucky, but because
sure.
it's emotional for everybody. And it is a change to you, because especially like I said, I have the mastectomy and things. It is something that you have to accept because it makes you a woman. And that is something that if you look in the mirror, you have to accept yourself. Yes. This is now me, and this is a new me. And this is how I'm going to look from now on. And then from there you will learn, other people will accept you, but you first have to accept yourself.
Absolutely.
And so, yeah, I'm on my tamoxifen. I see my oncologist every 6 months. So, and I just have that attitude, it's positive. I've got a second chance of life. So make the most of it.
Once again, thank you to both of you. And I hope that these stories, it might not help you now, and I hope you don't ever have to deal with this. But maybe these stories can help you help other people. And we've spoken about this from a patient side. And by the way, if you're like wondering, hey, what's happening here? This is a dialogue on cancer. It is a partnership between Brimstone Investments and Groote Schuur Hospital. Spoken about the patient side. Now let's find out about the people who do the treatments, the people who are there, who you put your faith in. If you ever had to undergo or get news that you have cancer, right? So, Dr. Julie Wettter, thank you very much. Can I call you Julie?
Please, of
course.
Okay, great. Definitely.
Okay, so Dr. Julie Wettter is an oncologist at Groote Schuur, and Professor Sulaiman Moosa is the head of radiology. So, before I'll do exactly what I did with these lovely ladies, I'm going to ask you about yourself first. Because before your X amount of years of studying and gave you this thing that you put on your card, before all of that, you're still a human being with families, right? So tell us a bit about yourself, Julie.
So I have 2 children. They're both teenagers now, both still at school, nearly 17 and nearly 15. Mm-hmm. I've been at Groote Schuur again, because I trained there, for the last 15 years. And that's pretty much my life, my children and my work.
Your children, and we'll definitely get to the work side of things as well. And obviously you're an oncologist, so we know what you do, but yes. I really want you to tell your story as well, which is going to be very important. Prof, from your side.
You can call me Sulaiman.
I can call you Sulaiman. Okay, great. Now that we've got all the... just about yourself first.
Yes, I'm married. My wife Najma. And I've got 3 children, 2 boys and a daughter. And I'm also a grandfather. I've got 2 grandchildren.
That's pretty special.
So I've got a similar journey. Trained at Groote Schuur as my basic training as well as my specialization, and been to a few other hospitals. And I came back to Groote Schuur a few years ago.
Brilliant. So public health care, right? You must sit at many dinner tables. Well, I don't know so much with what we've been through over the last year and a bit, but you probably sit around and speak to people who have lots of things to say about the public health care system. Julie, let's start with you. Do you find that this perception that public health care is really not going to do it for you, do you find that to be pervasive, or do you find that there's a general acceptance that actually, if I go to a Groote Schuur or any of the other hospitals, I'll get good care?
I wouldn't say that it's something that comes up in my personal life, really. I think most of the people that I know, certainly over the last nearly 2 years, have been very appreciative of everything that everybody has done.
Yeah.
I do think, though, that out in the community there is a perception that the care at a place like Groote Schuur or any other state hospital in the country is inferior. But not everybody feels that way. I think it's only some people that do, and perhaps people who haven't been exposed, to treatment there. And I think, we must narrow this conversation to the hospitals that we know of, that we work in, because I do think there are probably quite a few issues in other hospitals in other parts of the country. But certainly in the Western Cape, we are very, very fortunate. I think the academic hospitals here are very well run. I think the people that run them are very motivated to do the best that they can.
Yep.
And I think they are still, representative of what an academic hospital should be, a partnership between the state, which is service delivery, and the university, which is about training the next generation of doctors and also about research.
Yes.
And so we have all of that in the Western Cape, and we are very fortunate. And so I think a lot of people do realize that. The media is very kind and often publicizes things that that's new and innovative in a place like Groote Schuur. And so that does help. Mm-hmm. And I think the more people come through our doors and have positive experiences, the more they can go out and spread the news as well. So, and also you sometimes get people writing letters to the newspaper about their positive experience. So that does help as well. But
I found that when I've been on radio for a good couple of decades, almost 3, and we'd accentuate the positive. Because sometimes, you find yourself in a space where everybody's negative. And then you get the people who phone and go, I've been to Groote Schuur, I've been to Tygerberg, I've been to Red Cross. I just, as a father of a 4-year-old, I wouldn't want to live in any other province with my kid, because Red Cross Children's Hospital is probably one of the best on this continent, if not worldwide.
So I can speak personally about that. You want to know a bit about my family?
Please do.
So my son is nearly 15 now, but when he was 10, he was diagnosed with leukemia, and there was absolutely no doubt in my mind that he would be treated at Red Cross Children's Hospital, and the care there was incredible.
Yes.
There is something special about oncology. I think, as you said, the people who work there generally are in that field because they want to make a difference. They want to care for people in a very specific way, not always to cure, but to comfort and so on. But yeah, so that is something that I can mention. I don't normally talk about it, but just from the point of view of, I'm an oncologist, and I chose for my child to be treated at a state hospital, and that just speaks to the people that work at that hospital and what they can offer. There's something very unique about academic hospitals, and certainly the way ours is run when it comes to cancer treatment, and that is the multidisciplinary clinics. They're known as MDTs in America. We call them combined clinics. We tend to call them multidisciplinary teams now as well, same as in America. And that is something that is really our strength. There is a unique clinic for every sort of body site, so the breast clinic, the gynecology, the head and neck cancer and skin and so on. And there we have not only an oncologist present, not only ourselves, but we will be joined by people from elsewhere in the hospital who are interested in that particular field, and they will discuss each new patient that comes through our doors. We discuss it as a team, and we make decisions as a team. And that is quite unique to academic hospitals. And it means that every patient doesn't just have one doctor's personal opinion as to how to treat them, but has input from a surgeon, from, certainly when it comes to pediatrics, you'll even have, social workers and so on. We also have social workers, but they might have a psychologist who specializes in looking after children who are traumatized, and that really makes a big difference. It also helps with the registrar training. Registrars are doctors who are training to be specialists. and they get that exposure in decision making and in how to care for patients. We also obviously have input from palliative care. There was a time when palliative care was really the field of the oncologist. It was part and parcel of our job, and it still is. But now supportive care and palliative care is branching off and becoming a unique speciality on its own. So they will join us in discussing patients who need their input, and so there's this network of people who are coming together to discuss each patient. And then if the patient goes on goes into treatment and something doesn't work out quite right, or something needs an extra opinion, we bring those patients back into these combined clinics and we rediscuss them, and then make another decision together. And that really is our strength.
Tell me about the work of an oncologist. I mean, I hope it's not a silly question, but I think, tell me a little bit more about what you do on a daily basis, the sort of things that you, we know what you deal with,
yes,
but a little bit more nuance in terms of the job that you do.
So at Groote Schuur and at Tygerberg and in a few other places in South Africa, but not all of them, we are what we call clinical oncologists. So we train as radiation oncologists, but we are also trained in the use of chemotherapy. In America and some other countries, chemotherapy will be administered by a medical oncologist, radiation by a radiation oncologist. We do both. And I think that's also very important because the patient doesn't have to go from one doctor to another.
Yes.
In some places, if you have breast cancer, for example, you will have to go for your checkups every couple of months to 2 different doctors, and both of them will check you, and it's quite disjointed in many ways. But we treat our patients as a whole, and in the public sector, in an academic hospital, our job is to look after patients, and that's the majority. Well, that's the most important part of our job. And we spend more time doing that, but at the same time we're also training these registrars. And the way we can do both is that they are apprentices, really. They are watching what we do, they are joining in with us when we talk to patients, they are watching, they're making decisions with us. And so that teaching is the other very important part of what we do in an academic hospital. That's not really what you do if you're an oncologist in the private sector. So we administer chemotherapy, we administer radiotherapy. Radiotherapy has become very technical in the last few decades. It has really transitioned into the realm of technology, artificial intelligence. Yeah. When our artificial intelligence goes down, it means we can do nothing yep. for that period of time. We plan all radiotherapy using software and computers. The doctor decides exactly where the treatment should be, and then our planning radiographers will then plan it, and we will then come and have a look at what they've done, and we have this conversation between us as to which is the best treatment plan to use. Those are the same ladies that you talk about who treated you on the machine, and they almost universally, I have never had a patient ever in my entire career who's complained about the way they've been treated by the radiographers. They are very special people, and they really look after the patients with great love and care. And so we supervise the radiotherapy, we take responsibility for the radiotherapy. There's also a whole aspect of quality assurance, or safety is another way of putting it, with radiotherapy. The large responsibility for that is largely taken by the physicists. That's another part of our team. But we are obviously ultimately responsible for what we sign off as being safe treatment for a patient when it comes to radiation. The other part is obviously the emotional and psychological support for patients who go through cancer treatment. I did mention palliative care.
Yes.
We are also responsible for listening, for caring. I think although palliative care is very important for some patients, just going through your treatment the first time round, you need to get a lot of support from the oncologist. It's important to make time for that. It's important that our registrars are trained to break bad news, to have difficult conversations with patients. And they are trained in that. We have a palliative care course that all our registrars go on that runs for a couple of months, and everybody is expected to do that. It's an online course. It's run all over the country. People from anywhere in South Africa can join. They need to have someone in their own centre who can act as a mentor, but other than that, anybody can do it. So that is quite a new development. It's not something that I had as part of my training. It was something you were expected to just pick up along the way, but that's a really positive change in the last couple of years. So it's a multifaceted discipline. It's really wonderful in that you have interactions with lots of colleagues, from surgeons to radiologists to nurses to theatre staff. It involves a lot of technology, but manageable. It's something that is quite challenging and enjoyable. And I think that's some of us go to theatre. That's another part of an oncologist's work. We implant radioactive sources into patients for certain tumours, prostate cancer being one of them, very well-known use. We also use it for eye tumours that are very small, and we actually put together with the ophthalmology department, put these eye plaques around the eye. They inserted, we designed them, our physicists supervise, and that's in children and in adults.
Right.
That sort of very specialized radiotherapy techniques and treatment is only available in an academic hospital. On that level, you can get it in a slightly different form available in the private sector, but we tailor-make our own eye plaques for our patients. We have a workshop. We have very specialized physicists who do that. So that kind of very specialized radiotherapy is only available in academic hospitals. Likewise, radiotherapy for children is only available in state hospitals, except with a very few exceptions. So not the chemotherapy that can be given in the private sector, but brain tumors in children and other tumors that require radiotherapy all over the country, only administered in academic hospitals. We have the advantage that we have anaesthetists who come from Red Cross, because very small children require general anaesthetics every day in order to administer radiotherapy, because they're obviously very frightened and they don't lie still. There are certain treatments that are definitely only available in the academic hospital setting. And I think that's important that people do realize that sometimes it is actually better to come to an academic state hospital, so to speak, for treatments. And I'm sure Professor Moosa will tell us a little bit about that as well.
The microwave ablation is something I definitely want to find out about. I read about that in the newspaper. But Sulaiman, head of radiology, you have a management position. I'd like to focus on it from that perspective as well. And we'll talk about the microwave ablation. So you got some good press coverage on that as well. The Premier was waxing lyrical about that too. But let's just talk about state hospitals, right? We don't have to spend too much time on it. I think Julie has given us a good overview of what actually happens in state hospitals. Sulaiman, there is this perception that substandard care is to be had in some public hospitals. This might be true, but the converse could be true as well, where you can get really bad care in private hospitals as well, right? In your experience, I mean, you're in a management position, you're head of radiology, just your perspective on that perception.
Yeah, I think that perception is probably not completely true. I think we are very fortunate in Western Cape to have this teaching hospital which is well equipped. So we use up-to-date equipment. So we have good scanners. We are well endowed with scanners. We have multiple scanners. So with scanners, I mean the large equipment that we use to make diagnoses with. So MRI scanners, we have CT scans, and all our equipment we keep up to date and on a regular basis. Things are replaced every 5 to 7 years. There's an expiry date to equipment. So there's a continuous replacement and it's a continuous maintenance contract that we have on our equipment. Everything within the safety parameters that we spoke about earlier as well. So on the whole, quality-wise, imaging-wise, we're doing fairly well. Often where we lack sometimes is staffing issues. Often the staffing quotas in public and private is not equivalent. We only attract about 15 to 20% of the staffing quotas in public service, but we look after 80% of the patients. So that's a component that we need to be aware of. But yet with that staffing component, we do able to do quite significant work. The other important part of our public service, especially in the Cape Town, especially at the Groote Schuur and at the Red Cross and same at Tygerberg, I'm sure that we have a core of people who makes their careers there. So these people who stay there for many, many years, and everybody circles around that. And once you have that stability, you can create an excellent service.
Yeah.
So on the whole, I think our public service, that the service we're giving for our patients is excellent. I often in my daily practice, when I see patients, I would ask them, how was your journey here? How did you find waiting in the waiting areas? How are you being managed by your own doctors? And very few times do I have a complaint.
That's good.
Yeah. So often often the waiting times are longer than we want them to be. Often our people travel earlier. They leave home at 5 o'clock and they're there at 7 o'clock and they wait, and we only see them by 9 o'clock. Those kind of components do exist and we can't deny them. It's also a function of the demography of our people, where they stay and how far the resources are.
Yeah.
So there's lots of other components to it. But on the whole, I think our patients are happy with the service they get.
Yeah, I think I've had the pleasure of having a couple of chats with Dr. Keith Klute, for example, who's head of health in the Western Cape. What an amazing team behind him as well. So I would imagine that you guys get a lot of support from the department as well when needed.
Yeah, well, we get a lot of support. Well, starting at Groote Schuur, we have a very good management team that assists us, who listens to our complaints and address it in the best way they can. And also at the provincial level. I mean, we've had contact with Dr. Klute, and he's a man you can talk to and share ideas with, and some of it may fall in fertile ground. Yeah. And then you can do something with that kind of interactions.
Voet 'n plat op die aarde, like they say in Afrikaans. But let's not talk about management at the departmental level. Let's talk about the treatment of cancer, which is why we're here, right? So take me through the day of head of radiology.
Yeah, so maybe let me start by telling what the radiologists do.
Yes.
Because it's often so radiologists don't actually impact on therapy. But what they do is they allow doctors to make good decisions. So that is their core business, is to create create images about the disease processes,
right,
that allows doctors to actually administer treatments to make the best possible decisions for that patient. So radiology comes in a number of varieties, and some of them basically it can be as diagnostic radiologists, where we make diagnoses, right, and another component is intervention radiology, where we do some therapy. Mm-hmm. And what you mentioned earlier was the microwave ablation is a part of therapy. But lots of people know about radiology, maybe, for example, with a mammogram. Mm-hmm. So some mammograms are screening mammograms, meaning the patient is asymptomatic, they're at a risk level of some sort, and they go for a scan, and either the scan is normal or there's some abnormality detected. Mm-hmm. Often it's a very early disease. And from that, the patient goes on a pathway to determine whether this is benign or malignant. Yes. That's a screening component. But some patients have symptoms, or they may have a lump, or they have a cough, or they may cough up some blood.
Yes.
And then they go into a therapeutic process where we make a diagnosis for that patient. So either a chest X-ray, we see there's a nodule, or the patient have a mammogram, we see there's a cancer, and then the next step is to get tissue from that area, and that component is in the component which I mentioned earlier, which is the partly intervention, but still on a diagnostic process.
Yes.
So that to get tissue from example from a breast lump, we may do it ultrasound guided. So ultrasound is a machine that gives ultrasound waves into the body, and when the waves are reflected back, we can determine the tissue in between the probe and where the waves went.
Right.
And using that technique, we're able to put in fine needles into a tumor, for example, and take some cells from it. So that is a image-guided biopsy. And that's common in breast cancer.
Yeah.
But the same thing can happen maybe in lung cancer, where we put under a CT scan, which is those long, large X-ray machines. With people may know them with a tube. You move in that machine, and then under that guidance, we're able to put a biopsy needle into the lung and take some cells or take a small amount of tissue. So those are interventional procedures. So that's a different components of a radiologist's work. Partly screening and
Right.
looking for asymptomatic patients, and partly diagnostic, and then partly interventional as well.
So interesting, Julie, because you were talking about, the multidisciplinary approach to a patient, right? It would be interesting if you just take UCT, for example, as an institution. There are other departments. You were mentioning artificial intelligence earlier. I personally worked with a team that diagnosed, we can't call it diagnosed, but spotted TB, especially in remote patients, because this is the other issue, right? When you live close to, in urban areas, you've got access to the big hospitals. But if I'm living in rural South Africa, who's going to spot my TB? Or whether I might potentially have a problem. So at a state hospital level, things like artificial intelligence, what is happening there, just in terms of more advanced treatments? We will get to the microwave ablation, because that's the big one I want to talk about, right?
Yeah.
But do you talk, further than just the medical side of things? Do you engage with, people who are involved in the artificial intelligence space at universities, etc.?
Yeah, no, very much so. So artificial intelligence has arrived in our institutions already,
Yeah.
and in some areas we're using it. So artificial intelligence basically in radiology
Yeah.
allows us to work faster.
Yeah.
So some of the routine and mundane work that we need to do, the measurements of certain things,
Yes.
if you have artificial intelligence, it allows you to do that quickly,
Mm-hmm.
and you as a radiologist would then adjust those parameters.
Right.
So something which would take you 15 minutes to do is done maybe in 5 seconds.
Yeah.
So that's the strength of artificial intelligence. It makes us work faster. So in some aspects of our work, especially like my interest is cardiac MRI.
Mm-hmm.
So in cardiac MRI, part of the post-processing is to look at the heart in different
Yes.
components, and the artificial intelligence we use in those systems currently already implements those measurements for me. And all I have to do is to look at it, to adjust it, to make sure that it's correct, and then within a few minutes, which it took me half an hour before, is now completed in 5 minutes.
That sort of efficiency can save a life.
That efficiency, so that
Yeah.
allows the throughput to go through as well. What you're talking about earlier is something that we are currently also involved with, is looking at X-rays
Yes.
and finding mechanisms which artificial intelligence can make assessments of X-rays.
Yes.
Right? The one that we personally involved in at Groote Schuur, and as a project we're doing now, is looking at COVID-19.
Yes.
Whether the established modalities, artificial intelligence that can read X-rays, are they able to quickly read a COVID-19 disease process as well? So we know for TB it's very good for AI reading systems, and there are many on the system. Many of them currently that are being used in the open environment and purchased. Some people are using it, and some countries are being used quite a while already, especially like in India. But in South Africa, we were supposed to have a meeting last week talking to about a vendor about implementing that at Groote Schuur Hospital, a system like that, maybe as a trial. So artificial intelligence is certainly part of our regular discussions, and that's just a space that's going to grow and grow.
Yeah. And this is the public hospital space, right? And I remember, hearing some of the stories and just exactly what you're talking about, and going, a lot of this is not even happening in the private sector. I'm not here to knock the private sector, but because of your multidisciplinary approach in academic hospitals, it lends itself to this. Now, I don't want to, and by the way, when we talk about artificial intelligence, everybody's going like, what in the world is all of that? I mean, people are going to throw words like algorithms out. But I mean, all an algorithm is, right? It's some mathematical computation that. So let's just say you get an X-ray, a picture. That picture is just data to the computer.
Absolutely.
The algorithm allows the computer just to make sense of that data, the raw data that goes in, and that's essentially what it is. But now let's talk about this microwave, what's it called? Ablation.
Yeah, microwave ablation.
Microwave ablation, yeah. Tell us about that. That is a big thing. What does it do? You said it's therapeutic.
Yeah, it's therapeutic. So if you got a lung lesion, there's maybe you can think about 2 ways you can treat that, or maybe 3. But the surgically is the one way you can go in and you can remove it.
Right.
But more and more we want to do things that are less invasive. So we want to actually enter that lesion with a probe, maybe the size of less than the size of a pencil.
Wow.
So a thin probe, enter into the lesion, just focusing on that lesion and delivering delivering amount of energy there that allows us to destroy just that lesion. So there's no cutting of the skin, no cutting of the bones, of the muscle layers and the pleura, none of that happening. Just doing something, focusing on where the problem lies.
Right.
And that's exactly in a nutshell what microwave ablation is. So for lung cancers, some of them, small ones, which can either be primary lung cancers or maybe spread from other areas, like example colorectal cancers, when they spread to the lung, for example.
Yes.
In the right patient, and often the right patient is determined by the multidisciplinary team. I mean, people agree that this is the right patient who will benefit mostly from this treatment. You can arrange, in this case, under the CT scanner guidance,
Right.
A small needle being placed into the lesion. The patient is asleep under general anesthesia and the correct environment, so this patient is pain-free. And within 5 minutes, if you're able to deliver the right amount of energy in that area, and then the patient is cured of that problem. And the cure rate is fairly high. For a lesion under 2 centimeters, the cure rate is in the range of about 90%.
Wow.
So it is fairly. So this is a new thing for us. I mean, we have used other ablative techniques in other parts of the body. For example, the liver, we use radio frequency ablation. But for us at Groote Schuur, because we have some individual, we have a very talented radiologist, Dr. Conita said Hartley. In fact, she was supposed to be here tonight. She's very talented and skillful. And when this opportunity arose, and with the necessary skills that she's developed over the years, she was able to perform the very first one. And we're very happy with the result. The patient has done very well. And I think going forward, this is an area that's going to grow. In fact, in the UK, they're thinking this technique is going to enter in a range of about 5,000 patients per year. I mean,
Wow.
it is that kind of a range of people will be helped with this technique.
And that's the beauty of where we are. The challenge is we are going to be faced with all our challenges, right? For one person, it might be cancer. For another person, it might be something else. And to know that we have a public healthcare service, especially, as we said, I mean, maybe it's not the same everywhere, but we have real dedicated doctors, professors, trying to make a difference, making a difference, embracing technology. I just think that's wonderful. Absolutely. Which is really, I hope that is the point that we bring across through these conversations that we have. But I'd just like to, I mean, in closing, right? So I could talk for another hour. Maybe I should ask a lighter question. Do doctors ever sit and watch series like The Good Doctor? No.
Well, I
Do you
watch
ever watch
series,
medical
but
series?
not The Good Doctor. Not medical ones. I used to watch ER long ago, but no, I don't. I don't enjoy watching medical series at all. Other ones, but not those. No, I don't know how Sulaiman feels about it.
Yeah, I mean, neither.
There's too many inaccuracies, and it gets
Yeah, but this is the
annoying.
thing, right? This is why I'm asking.
Yeah.
I just want to thank everybody for, I mean, first of all, you know, the brave stories you told and taking us through that journey, much appreciated. and to you, the doctors involved in providing the care. And I just want to thank, the Brimstone Investment Corporation for making this possible. The Brimstone Investment Corporation, I happen to have known over the last couple of years, and they're very involved in the community, trying to make a difference and also giving back, because it's a company where, the executives have actually come from the community. And that's just wonderful. In Groote Schuur Hospital, an academic hospital where I think you're doing things the way it should be done. Things should be multidisciplinary. The patient should be treated as a whole. And not everybody's got the benefit of that. So I think for me, listening to the stories from the medical side, from the patient side, looking at how the public sector, especially our academic hospital, Groote Schuur, adopts technology, cares about the whole person, and you didn't just hear it from the doctors, you've heard it from the patients. It really gives me great hope. The public healthcare system will save your life. And I think we should all be thankful that we have a public healthcare system like the one we have in the Western Cape. And once again, thank you very much to Groote Schuur Hospital, as well as the Brimstone Investment Corporation for making this discussion possible.